and we'll kind of, by the end of this lecture, hopefully we'll be able to describe what exactly is going on here and what's involved. All right, so let's get into that. So I have some numbered things here, and we're going to kind of go through them, and I'm just kind of give you some ways of thinking about this that makes it easier for me. And so this is an axial image of the uh, temporal bones on the right side. So this is the right side of the image here, which appears on the left side of the screen, of course, in radiology, but this is the right side of the image. And so this is, what we can't see here is the external ear, but the external auditory canal would kind of come into here, and what we have is a zoomed up image of the CT of the temporal bones. And so let's just kind of start naming things. So right here, number one is uh an opening or a pathway that kind of goes from the mastoid air cells, which are here, go from the mastoid air cells eventually into the middle ear. And so number one is going to be a mastoid antrum, as we have here on the right side of the screen. And so so this is sort of the opening of the mastoid air cells into this pathway that will eventually end up in the middle ear. Number two is the actual name of the pathway, which is the adytus ad intrum. So in Latin, that adytus ad intrum, I forget exactly what it means, but it refers to essentially a pathway between these two structures. And then number three is going to be the epitympanum, which is uh, the superior aspect of the middle ear cavity. Uh, and so we see there is a direct connection between the mastoid air cells and the middle ear cavity, and we'll see later on the relevance of that. And then number four here, as we have listed here, is one of the semicircular canals. And so we have a lateral semicircular canal here specifically. It's attached to the structure called the vestibule, which is number five here, which is also an inner ear structure. So the semicircular canal and the vestibule are both inner ear structures. So right here, number four again is the lateral semicircular canal, and then the other semicircular canals are basically traveling perpendicular to the axial plane, and that includes the posterior and superior semicircular canals. And we'll see a diagram of that in just a second. And number six here, as we have over here, is part of the facial nerve. We're going to look at the facial nerve in a little bit more detail later on, but you can see inner ear components here. We can see the middle ear, and also we can capture the facial nerve. And this is going to be very important because if a patient has symptoms related to facial nerve pathology, and it may be in the setting of something such as trauma or a temporal bone fracture, and so you have to think about those things. So if a patient has facial nerve symptoms in the setting of trauma, you have to think about the facial nerve potentially getting injured because of a temporal bone fracture. And then we have internal auditory canal here is number seven, and it's cranial nerve seven and eight will go through here. So seven comes out this way. Eight is called a vestibular cochlear nerve, and it goes to this vestibule, which we saw here in the cochlea, which is out of plane, but we'll see in a second. And then I already mentioned the posterior semicircular canal. So one more time, the mastoid air cells go into this hallway that added this pathway in between the middle ear and the mastoid air cells called the adytus ad antrum. The epitympanum is a superior aspect of the middle ear, and then we have a lateral semicircular canal, but we also gonna have a posterior semicircular canal and a superior semicircular canal. These semicircular canals, we were saying, are part of the inner ear, as is the vestibule and the cochlea are also parts of the inner ear, but we can't see the cochlea here. And then we have this facial nerve course, and again, seven and eight go through this internal auditory canal. So let's look at the semicircular canals in a diagrammic fashion. And so, as I said, so the axial plane, this is kind of looking at the semicircular canal in, I would say, like maybe a sagittal or coronal plane, right? In this plane, The the lateral semicircular canal looks much more perpendicular, but we can kind of see how these structures kind of relate to each other. And so this rounded like bulbous structure is the vestibule, and then we have the lateral semicircular canal. And as I said before, perpendicular to the axial plane are going to be these posterior and superior semicircular canals. Um, and then the epitympanum, just want to talk about that a little bit more. So we said this is a superior or highest portion of the middle ear cavity. And so here's just in a diagrammic fashion, like a diagram of how this actually looks. So this is the tympanic membrane or the eardrum, as we say colloquially. And then where the tympanic membrane attaches superiorly, everything above that within the middle ear cavity is the epitympanum, the parts in between the superior and inferior attachments to the middle ear cavity, or the mesotympanum. Below this inferior attachment is this small hypotympanum. So these are the parts of the middle ear cavity: hypotympanum, mesotympanum, or an epitympanum. The middle ear cavity is also called the tympanic cavity. So middle ear cavity is tympanic cavity. Pars flaccida and pars tensa will come into play a little bit later, but just remember right now that they are describe parts of the tympanic membrane, but they will come up later in a pathology known as cholesteatoma. So kind of going forward, let's look at our first anatomic pathologic correlation here. And so we see these structures that we described before. And so what's going on here? So in this case, let's see if we can try to figure out what's going on. So we said this was the internal auditory canal here. We said this was the labyrinthine segment of the facial nerve. So this is part of the facial nerve coming up here. We can identify the vestibule here, and one way to identify the vestibule, besides just looking at this sort of this bulbous structure here, is that you have the internal auditory canal coming in here, and we talked about the seventh nerve, which is the facial nerve, coming up here. But then we have a vestibular cochlear nerve, which is cranial nerve 8, that goes to the vestibule. And we can see this thin lucency going to the vestibule, and the vestibular nerve goes here, and then it also goes to the cochlea. So the cranial nerve 8 goes to the vestibule, and we see this little thin line. So internal auditory canal carries 7 and 8. This thin line, the vestibular nerve specifically, is going into this vestibule. Then we see the lateral semicircular canal here. And so what's wrong with this picture? So we saw in the normal case, we saw fluid fill these internal ear structures, the vestibule and semicircular canal are filled with fluid. But in this case, we see this little really, really dark spot here, and that's air. Likewise, or sort of alternatively, or different from the inner ears to middle ear. In the middle ear, we saw that it was filled with air on the CT here, but in this case, we see it's filled with fluid. And so when you have a little bit of air in the inner ear cavity and a little bit of fluid in the middle ear cavity, you start thinking that there's an abnormal connection between the two. And in fact, that's what we have going on here. And we call this a labyrinthine fistula. And so again, the clue is air in the inner ear in the same time that there's fluid in the middle ear. And remember, there should be air in the middle ear, and it should be like fluid in the inner ear. And so when you have the reverse of that, then you start thinking about a labyrinthine fistula, also called a paralymphatic fistula. And it happens often in the setting of trauma. It doesn't happen, you don't always see it immediately, but it's certainly something you can see especially as the patient starts to, some time passes after the trauma. So let's go a little bit more inferiorly. So we started here on the left side of the screen, and we're going a little bit inferior to that. And now we're looking at another axial image. Again, the external auditory canal will be out here. This is the right side again. And so we again see the mastoid air cells, these little multiple bony septations we expect to see with the mastoid air cells. And so that's number one. Number two here is the incus, and number four is the malleus. So the malleus and incus make up two of the structure of the middle ear ossicles. So there's also middle ear ossicles or middle ear bones. So these are these tiny bones that play very crucial roles in one's ability to hear. And so we have 2 and 4 here, and as well as sorry, we have 2 and 4 here, as well as the two is the incus forcimalis, and then we have 3 is the incutomalleal joint, which is just the articulation between the incus and malleus. Are people still able to hear me okay? Just wanna, hello?
Yes.
Yes. Yes.
Okay, good, good. Okay, thank you. All right, yeah, I'm using a hotspot on my cell phone, and I was just trying to make sure you guys are able to hear. Oh, okay. So, tympanum, we talked about that before, is number 5. Again, that's the superior or upper aspect of the middle ear cavity. And then we have 6 and 7 here. So 6 and 7 are parts of the cochlea, as is number 10. So all these are parts of the cochlea. Modiolus is something you probably won't hear very much, but it's just a spongy bone in the middle of the cochlea. But remember, we talked about the vestibular cochlear nerve, which is cranial nerve 8, which comes through this internal auditory canal along with cranial nerve 7. So cranial nerve 8 will come into here and is called a vestibular cochlear nerve again. So it goes to the cochlea and the vestibule. So you see these very thin lucencies here where the vestibular cochlear nerve will divide and go into the vestibule and the cochlea. And so here's the cochlea. Specifically, number 6 refers to what's called the basal turn of the cochlea, which is the outer turn of the cochlea, or the base. And we'll see a diagram or a picture of the cochlea in a little bit later in the presentation. But the outer turn is called the basal turn. There's a middle turn, which is number 7 here. Then there's going to be an inner turn, which is called the apical turn. So there's an apical turn in the middle, which is going to be the smallest of the turns. We're going to have a middle turn and then a basal turn. We'll see that a little bit later in a diagram. Number 11 again is the vestibule. We see the vestibular nerve coming up to here. And again, the vestibule is going to be connected to these semicircular canals. We saw that in a diagram previously. Number 8 just refers to the otic capsule, which is the capsule is the this really hard bone that surrounds these inner ear structures. So all this is otic capsule is the densest bone in the head, basically. And it's in so and just want to show you a diagram of the articulation of these structures we talked about before. So number 3, we said it was the incutomalleal joint, and so it would be like right here. And then we talked about the malleus and incus. Why am I showing you this picture? Just to tell you that as you kind of look at temporal bone CTs, what you'll notice is that the anatomy looks very different depending on the anatomy of the middle ear ossicles looks very different depending on how you're viewing it. So if you're looking at it in a coronal plane, it's going to look very different from how it looks in the axial plane, potentially. Or if you're scrolling through the axial plane, you may see an image where these bones look very different, and it's just have a very, sort of a complex three-dimensional arrangement. So that's just to let you know that that exists. Here's another anatomic pathologic correlation here. So we talked about this otic capsule surrounding these inner ear structures, and what you notice, the bone is very, very dense, and that's a normal situation. Well, what about we see this small red arrow here? What it's pointing to is an area of bone that is not as dense. And so when it becomes a little bit more lucent, that's actually a pathologic process. Again, this bone should be very dense, but we see here a little bit of lucency. Sorry, the picture's a little bit grainy here. So this is how the bone should look up here on the image on the we see in the image on the upper half. This red arrow is pointing to how normal bone looks, very, very dense. And when we have this less dense bone, that's when we get concerned. So this is a process called otospongiosis or otosclerosis. And it's called these two names because at first is the otospongiosis part is sort of this less dense bone. And the otosclerosis part, it can over time become a little bit more sclerotic. So the most common version of this is the fenestral otospongiosis. And so the fenestral otospongiosis is gonna be in this location here. And so when we say fenestral and retrofenestral, is from the sort of from the perspective of let's say an ENT doctor who's looking into the ear. And so what they will see is if they're looking into the ear, they would, technically encounter spongy bone here before they would encounter it here. And so when the spongy bone is sort of on this side of the cochlea, which is deeper, that's when it's retrofenestral versus fenestral, which is when it's a little bit closer to the external ear. So here's an example of retrofenestral otosclerosis. Again, we're catching part of the internal auditory canal and looking at a part of the cochlea, and there's just too much lucency here. And again, this is if someone was looking into the ear, they would be looking in this direction. This retrofenestral otosclerosis is kind of deep here, and that's the typical appearance. Often this can occur bilaterally, and so we see it on the other side as well. And then we see a congenital issue here. So on the left hand side, on the right hand side of the screen again is our normal example. And we see a normal cochlea. It has sort of this clover leaf appearance. And then we see a normal vestibule here. And we don't really see the semicircular canals, but probably part of it poking out here. Here's an abnormal case. In this case, we see part of the semicircular canal here, but it looks distorted. And so when especially in the pediatric population, when I'm looking at a pediatric case, what I always keep in mind is looking at a pediatric case makes me think to myself, well, I really have to know the anatomy, the normal anatomy really, really well, because with the pediatric case, you may have malformations of the cochlea, of the vestibule, and the semicircular canal. And when you really study this and spend time with it, you'll realize that there are not very many structures to memorize. And once you do memorize them, they become really easy. It becomes really easy to notice pathology. And so I can look at this and notice that it's malformed, but I would encourage you to spend a lot of time just kind of looking at the normal structures. Again, it's not very many to know, right? We talked about cochlear, internal auditory canal, the facial nerve, which we'll see a little bit later. We talked about the semicircular canals. So it's not very much to memorize, but once you memorize those structures, it becomes a whole lot easier to notice abnormal pathology. Um, so let me go forward here. This is an example of cochlear aplasia. And so what we see here is the vestibule, the semicircular canal, but we don't see a cochlea. And it's hard to tell this on a single image, but if you scroll through, you would notice there's no cochlea. This patient, of course, presents with hearing loss, as you might imagine. If this is a pediatric patient, it may be hard to figure that out early on, but that's what you should be able to pick up hearing loss clinically. So just looking at our next image here, wanted to illustrate another process here. And so the question is like, of course, what's abnormal here as we scroll through? Well, I'll tell you, oops, let's go back here. I'll tell you the normal side is the one with the lucency, right? These inner structures should again be lucent. The abnormal side has increased density within the cochlea. So this should be the basal or outer turn of the cochlea, but right here is filled with bone. The middle turn is right here. So this is filled with this increased density. And so what are we looking at here? Um, so this is labyrinthitis ossificans. So this is pathologic ossification of the membranous labyrinth, right? So the membranous, so there's an osseous labyrinth and there's a membranous labyrinth. The osseous labyrinth refers to the bone outside of the membranous labyrinth. So the membranous labyrinth is within the osseous labyrinth, and so the membranous labyrinth refers to the low density areas within these inner ear structures, and so should not be filled with this increased density. Again, comparing to the normal side, comparing that to the abnormal side, we see this increased density. We did say before that right in the middle of the cochlea is this mildly increased dense area called the um, oh man, I'm blanking on what it was called, the modiolus. Brain's not working today. So the modiolus is here, and that's a normal, like increased density, spongy bone that is normal. But beyond that, it should otherwise be lucent in the cochlea as well as the vestibule and the semicircular canals as well. All right. So we also see the lateral semicircular canal involved in this labyrinthitis ossificans. This again is something that can result from old trauma, old infection, and eventually the body in sort of in an immune response will create this ossification. All right. So going forward, here's another path. uh, I don't really want to call this a pathology, but it can cause pathology if it's not dealt with appropriately. But basically, let's just scroll through here and see if there's a difference. And so the white arrow is pointing to a variant of normal, which we can see in pediatric populations, but often this isn't actually caught until adulthood. But basically, the this represents the carotid canal. So the internal carotid artery is traversing through this canal. It should not traverse um, along the outside of the inner ear structures, but in this case, it does here on the right side. And so this is called an aberrant ICA. And the ICA again should cross the middle ear from posterior to anterior. Sorry, in this case of the aberrant ICA, the ICA crosses the middle ear from posterior to anterior across the cochlear promontory. And so the cochlear promontory is just where it's just this bone overlying. So this whole area is called the otic capsule, but the cochlear promontory is specifically this bone overlying the cochlea. So when you hear the word cochlear promontory, think bone overlying cochlea. And so the ICA should not pass over this bone. When it does, that's when we start getting concerned about an aberrant ICA. So I told you that this could potentially be associated with pathology. Well, why is that the case, right? Who cares if the ICA is taking an abnormal course? Well, it's important if this aberrant ICA is potentially confused with this other lesion, which is right here. This is a glomus tympanicum paraganglioma. So this may be causing something such as like pulsatile tinnitus. Maybe it's causing hearing loss, but this is a neoplasm. It's a relatively benign behaving neoplasm, so it's not concerned that the patient will like die from this. But the patient would die if, not to be morbid, if you were to confuse this with an aberrant ICA. The aberrant ICA goes over the cochlear promontory just like this structure does. But obviously you don't want to try to resect the ICA, but you would want to resect this tumor. So how do we distinguish this tumor from the ICA? Well, this tumor would not be continuous with the ICA, and so that's why it's really important to be able to scroll through these images. Um, Here's another differential diagnosis of the aberrant ICA is called a dehiscent jugular bulb. And so there should be so we have the ICA up here, but in the back we have the jugular vein. Sorry, the internal jugular vein. And before we get to the internal jugular vein, we have a sinus system within the brain, which are called the durovenous sinuses. Eventually, they're gonna kind of go laterally and anterior And but there should always be bone over these structures. And here we don't have any bone, and so this is called a dehiscent jugular bulb. Again, a lot of these patients, just like a lot of patients with inner ear pathology, will present with something like pulsatile tinnitus, ringing in the ears, and it feels like a pulsating phenomenon. And or they may have something like hearing loss, and so that's the other differential consideration. So let's look at this third axial image. I'm going to spend less time here because we're at this point just naming some of the same structures over and over again. So this is just one, two, and three just goes to show you how we saw in this 3D diagram how these middle ear ossicles have sort of this complex 3D arrangement. And we can kind of see how it doesn't line up in the nice ice cream and cone appearance we saw of the incus and malleus earlier. Now we see how these bones are kind of, depending on where we are, can kind of look a little bit different. But the middle ear structures from lateral to medial would be the malleus, which is number three here, incus and stapes. And then there's eventually we're going to come up to the oval window. And so I had a old colleague in neuroradiology had a little mnemonic miso. Um, I took Japanese and we'd talk about miso soup, so MISO. And so M being the malleus, I being the incus, S being the stapes, and O being the oval window, and going lateral to medial miso. Um, we also see a few other structures, tensor tympani. Not really going to get into it here, but it's just a muscle involved in tensing up the tympanic membrane. And it's important for hearing. We talked about the carotid canal already. Again, we're looking at the basal turn out here on the outside of the cochlea, the middle turn here in the inner turn, six, seven, and eight. This inner turn also called the apical turn. And then there's just a little piece of bone between the basal turn and the middle turn. And again, it's important to know what's normal density and what's normal lucency. We don't see the modiolus, which is that spongy bone in the middle of the cochlea. We don't see that on this image, but remember that it's there. There's also a round window. We talked about the oval window, which would be around about here. There's also a round window here as well, which is also important for hearing and connecting inner ear and middle ear structures. There's a vestibular aqueduct, which is number 11 here. We're going to see that in a little bit when it comes to some pathology. Here, I don't want to get into this a whole lot. There's a little mnemonic I even used today, SPF. And SPF just refers to these main structures. So S being the sinus tympani, and key pyramidal eminence, number 14. And then 16 is the facial recess. And so why is all this important? Well, the facial recess is going to be anterior to the facial nerve. So number 15 is facial nerve. So facial recess anterior to the facial nerve. So SPF, pyramidal eminence is going to kind of stick up here. But the main reason I kind of pay attention to this is that the facial nerve is going to be right behind the facial recess. All right, so we talked about looking at the cochlea in a different way, and this is the way it actually looks from a three-dimensional standpoint. Kind of looks a little bit like a snail. We see the semicircular canals up here, the vestibule here, but we see the cochlea turns there. All right, so and here's just another 3D version of how the malleus, incus, and stapes look. And so malleus here, incus here, stapes here, and we're going from lateral to medial. And then there's a stapes foot plate, which is going to attach to that oval window, MISO, miso. All right, so the vestibular aqueduct can be enlarged. So the vestibular aqueduct should actually be the size of the posterior semicircular canal. If you can't remember that is 1 to 2 millimeters in size. That should be its maximal size. But if you can't remember that, just remember it should be the size of the posterior semicircular canal. So the posterior semicircular canal is going to be the semicircular canal that's closest to the vestibular aqueduct. So when it gets too big, which is the case here, is bigger than 2 millimeters, so it's enlarged, it's bigger than the posterior semicircular canal. It's too big. That suggests that there's a problem with the endolymphatic sac. So these patients will present with congenital hearing loss. And as a matter of fact, I think this is the most common cause of congenital hearing loss, or one of the most common causes. Let's talk about the facial nerve here. We were saying, we were talking about it earlier. Again, we go into the internal auditory canal. There's this labyrinthine segment. Labyrinthine starts with an L, and this to me looks like it's sort of like we're going into an upside down L. But then there's a bend or a genu. You think about genus, it's used in other terms like genu varis or valgus when we're talking about the knee. Genu just refers to to this bend, and so we have the genu of the facial nerve, and we actually have a bundle of a ganglia of facial nerves up here for the bend, and then we're going to kind of come back, and we're going to become the tympanic segment. So we have a canalicular or meatal segment of the facial nerve, which traverses the internal auditory meatus or internal auditory canal, labyrinthine segment, this genu, and then this tympanic segment coming back here. Let's scroll through a little bit and look at these. So again, internal auditory canal, labyrinthine segment to me looks like an upside down L. Labyrinthine starts with an L. Tympanic segment, just notice that the tympanic segment, the way I remember it, is that it's the part of the facial nerve that's adjacent to the tympanic cavity, right? So here's the tympanic cavity. We said that that was another name for the middle ear. So the facial nerve segment that's adjacent to the tympanic cavity is called the tympanic segment. And so and we see it as a thin line kind of moving with us, I would say parallel to this axial plane, right? So again, this is the right side of the patient's head. We see the part of the like the earlobe out here, and we see the mastoid air cells. But here's the facial nerve; it has this blue line on it, and so this tympanic segment again moves parallel to the axial plane, and then eventually we're going to get to a posterior genu, and at that point the facial nerve is going to travel perpendicular to the axial plane, right? So it goes parallel to the axial plane. Now it's moving perpendicular. The mastoid, and so going from this parallel to perpendicular orientation basically is where we're going to have a genu going from one part to the other. But more importantly, now we're going from the tympanic segment, which is next to the tympanic cavity, to the mastoid segment, which is right next to the mastoid air cells. And so that's the way I remember it. All right, eventually this is going to exit through the stylomastoid foramen. How do we remember that? Well, the stylomastoid foramen are close to the mastoid air cells in a styloid process. And so here's the styloid process right here. Here are the mastoid air cells, and the stylomastoid foramen is next to the mastoid air cells in the styloid process. Here's another look at the stylomastoid foramen, but more importantly, the mastoid segment. So the mastoid segment of the facial nerve is right next to the mastoid air cells, and then we have a posterior genu, which we can see right here. This is the facial nerve transitioning from the tympanic segment to the mastoid segment at this posterior genu. All right, so we see pathology here again. So we see the mastoid segment. We remember on the prior images, the facial nerve was always pretty small. When we see a focal enlargement, we have to think about pathology. Most commonly, that's going to be something called a schwannoma. And so we also have these schwannomas, which are these nerve sheath tumors. Again, they are like benign behaving, just like the paragangliomas, relatively benign behaving. But these schwannomas are most commonly on cranial nerve 8, followed by 5, but then they can also appear on 7. And when they do, what you might see is an enlargement of the mastoid segment, for instance. All right, so coronal anatomy, not going to spend a lot of time here. Um, uh, going to highlight just a few things, but and the reason why I'm not going to spend a lot of time here is because we're covering some of the same things. Do want to show you the relation between the external auditory canal and the middle ear cavity here. So the tympanic membrane should be approximately right here, and that separates the external auditory canal or the external ear from the middle ear. Um, And let's move forward here. And we're going to look at this structure called this is gonna come into play here. This is a structure called the scutum, which is number 11. It's just a piece of bone that's gonna be separated by the from the middle ear ossicles by a space called Prusak space. And so this is the main thing I want to show you on this image. This area here. So we have the malleus and incus. We have this Prusak space, and I'm telling you, talking to you about this because there's going to be an important pathology that occurs here. Number 11 refers to the scutum. And then we have the tympanic membrane, which again separates the external ear and the middle ear. All right. And so just highlighting again, so everything above this superior attachment of the tympanic membrane is epitympanum. Everything in between the superior and inferior attachment of the tympanic membrane is the mesotympanum, and everything below that is the hypotympanum when we're referring to the middle ear. So these again are components of the middle ear cavity: epitympanum, mesotympanum, and hypotympanum. If you're saying to yourself, number 10 refers to the tympanic membrane, but I can't see it, I fully agree. Not seeing the tympanic membrane is usually a good thing because the tympanic membrane should be so thin that it's barely perceptible. And so this is a normal appearance of the tympanic membrane. When you do start seeing it, it's usually because it's pathologic. Um, moving forward, we talked about the scutum. So what do you notice here? This is also a coronal image. You don't see the scutum. It should be pretty sharp. That's again number 11 right here. And then this Prusak space should be aerated and it should separate the scutum from the middle ear ossicles. But over here, we see the eroded scutum, and we don't see the Prusak space. It should be filled with air. Here's filled with an opacity. We don't see the middle ear ossicles. Well, that's problematic. And as some of you may know, this is we see this in the setting of what's called a cholesteatoma. Usually these are acquired, but can be congenital. But how do we know is a cholesteatoma? Well, often it's hard to tell, but one thing we see with cholesteatomas is that they tend to erode bones. They tend to push bones over, and they're really, really, really common. They tend to appear in the middle ear cavity. That's sort of the third feature. So they erode bones, push bones over here in the middle ear cavity. They're really associated with pathology of the middle of the tympanic membrane. Remember, we were pointing on a diagram to flaccida intensa parts of the middle ear of the tympanic membrane. And so these pars flaccida tends to be the most common types of cholesteatoma, and both flaccida intensa occur in the setting of tympanic membrane injury. So you'll often see a ruptured tympanic membrane, and a pars flaccida cholesteatoma will appear most commonly here in this Prusak space with erosion of the scutum and pushing over or erosion of the middle ear ossicles. And so that's a pars flaccida cholesteatoma. We also see this arrow is pointing to something called the tegmen tympanum. So tegmen refers to roof, and so we have a tegmen tympanum and a tegmen mastoideum. So number 2 is a tegmen mastoideum. Number 3 is a tegmen tympani, and these are just roofs of the tympanic cavity as well as the mastoid air cells. And so you can have these become you can have the tegmen tympani or this roof become dehisced in the setting of a cholesteatoma. And so a cholesteatoma is essentially and maybe the easiest way to describe it is that there are skin cells that are like essentially in the wrong place. Think of them like that. And so cholesteatomas, although they sound like these tumors, they're not like neoplastic in the sense that like they're not going to cause a patient to die from cholesteatomas. They occur a lot. They occur a lot in the setting of trauma, tympanic membrane rupture. Cholesteatomas also importantly, as I say, they erode things, push things over. But the other important thing is, although they're not neoplasms, like neoplasms, unfortunately, they reoccur. And so you'll take a cholesteatoma out, remove it, try to clean it up, and it will pop back up again. And so they can be really frustrating to deal with. Let's go back to, and we're almost done here. So let's go back to the trauma case from the beginning. that important. The only, but just so you know, for the purposes of, if you see temporal bone fractures, know that they're classified. So trans goes in this direction, a longitudinal fracture goes in this direction. So transverse this direction, longitudinal this direction. So that we can see that this fracture, it looks like it's gonna kind of cut through these mastoid air cells, and they're opacified. And so one of the common findings we see with a temporal bone fracture is opacification of the mastoid air cells. And so we see that here with this transverse fracture. But we also need to pay attention to things like the middle ear ossicles. So we see the malleus and incus right here. Here's our cochlea again, right? The basal turn out here, the middle turn right here, the modiolus, which is that normal spongy bone, the only part of the cochlea that should be dense. We see this interscalum septum, which is between the basal turn and the middle turn. We see the internal auditory canal. We know the vestibular cochlear nerve is coming up here. One's going to the cochlea, one's to the vestibule. Here's the vestibule. Here's the semicircular canal. And so here are the middle ear ossicles, and importantly, right here, these middle ear ossicles have fluid around them. Before, except in the setting of a labyrinthine fistula, we really shouldn't see opacity in the middle ear cavity. You'll see opacification in the middle ear cavity a lot, though. You'll see it a lot in otitis media, of course, which you see in children all the time. But notice something here. The temporal bone fracture is right here. But we see opacification of mastoid air cells. That makes sense. This is fluid here, probably some blood. But then it's also some fluid in the middle ear cavity. Why is that the case? Well, remember at the beginning we said there is a connection between the mastoid air cells and middle ear cavity called the adductus ad antrum, and specifically the epitympanum, or the superior part of the middle ear cavity. So here's that connection, allows fluid and blood to flow right from the mastoid air cells into the middle ear cavity. And so, does this patient have trouble hearing? Yes, certainly. So this patient will probably have pain around their ear, around their sort of like the back of their jaw, right? Then they're going to also describe problems with hearing. And that's how what might point you to a temporal bone fracture. From a radiologic standpoint, what we want to see is a pacification of these mastoid air cells. So just kind of going forward, what else is important? The facial nerve course. Do we see the facial nerve? Well, yes, we do see it. And so, in fact, it's right here, the tympanic segment we're kind of seeing right here. And again, the tympanic segment is a segment of the facial nerve that's passing close to the tympanic cavity. So we see it right here. So that's going to be the facial nerve tympanic segment. Important to see if this is involved with trauma. It's kind of hard to tell. I don't think it is, because the fracture line doesn't go through it. But fracture lines certainly can go through the facial nerve. And again, these patients may present with symptoms referring to the facial nerve. And then we talked about the inner ear structures right here. It doesn't appear that any of them are involved in this fracture, but important to pay attention to those. What does appear involved in this fracture is the temporal mandibular joint, right? So we have the temporal bone, and interior to that, we have the mandible. This is the mandibular condyle, and so this is essentially, the process of opening and closing your jaw requires a well-functioning temporal mandibular joint, and so here, when we have a fracture through it, this patient may have trouble opening and closing their jaw, which may be another telltale sign that there's a temporal bone fracture. But there's actually a small fracture here in the temporal bone part of this temporal mandibular joint, which we're seeing here. So we talked about the transverse fracture earlier. And here's now a longitudinal component of the fracture. Remember, we said longitudinal goes more so in this direction. It's not perfectly in that direction, but this is a longitudinal fracture nonetheless. Again, we see more opacification of these mastoid air cells, and so that's the longitudinal fracture right there through the temporal bones. So, in summary, knowledge of bone is crucial for identification of a spectrum of congenital and acquired pathologies. And so really, like, identifying and knowing like these inner structures, how the tympanic membrane is supposed to look, facial nerve. It wasn't much else that we talked about. We kept talking about the same things over and over and over again. And so I would really tell you, my to being able to understand what normal bone anatomy looks like is to just look at it over and over and over again. Um, and you should also know what normally contains air, what normally contains fluid. We talked about that, what should be ossified and what shouldn't. We talked about that. And also, look, this is common with all of radiology, right? Does the left side look like the right side? For the most part, that's going to be true unless you're talking about organs in the anatomy, like for the most part, otherwise, with down ending when it's finished, I spent a lot of time looking at love, especially when it comes to the temporal bones. That's all I have. Thank you so much for your time, and